Good afternoon, everyone. I'm presenting on behalf of Medicine 4 under the title The Follicular Folly. This is about Mr. R, a 55-year-old retired factory worker from West Bengal, came with intermittent episodes of cough for the last 5 years, which had worsened over the last 4 months, an evening rise of temperature, which was noted over the last 4 months, and vague pain over the left-sided chest for the last 3 months. Cough was dry with scant mucoid expectoration, responded to symptomatic treatment with antitussives. Fever was low grade intermittent associated with night sweats, and chest pain was left sided, sharp, and stabbing in nature. Outside reports had shown the presence of bilateral pleural effusions, for which therapeutic taps was done thrice in an outside hospital prior to admission here. There was also a history of loss of weight of more than 8 kgs in the last 6 months. His comorbid these include he was a known diabetic for the last 8 years on medication, but not on regular follow up. He's been a smoker since the age of 15 years, and he smokes 10 to 12 cigarettes per day. On examinations, he was vitally stable. He had a right upper cervical lymphadenopathy in the of size 2.2 into 1 centimeters, just firm, not fixed, not tender, and there were no skin changes noted. Likewise, there was left axillary lymphadenopathy, which was firm in consistency and not fixed to bone, and it was non-tender, and no skin changes were present as well. And subcentimetric inguinal lymphadenopathy was present bilaterally. Systemic examination showed RS in respiratory system. It was significant for a tracheal shift to the right. Normal vesicular breath sounds are auscultated bilaterally, but there was decreased vocal resonance and air entry in the left mammillary, axillary, and intrascapular regions. Also, abdominal examination, there was a vague globular mass palpable per abdomen. There was no organomegaly. There was no focal neurological deficit either. So, in summary, a 61-year-old diabetic and chronic smoker with gradually progressive chronic cough, evening rise in temperature, pleuritic chest pain with diffuse lymphadenopathy involving multiple non-contagious sites presented with left-sided pleural effusion, differential pulmonary or extrapulmonary TBs, malignancy, lymphoma, a small bronchogenic carcinoma, small cell carcinoma, or primary effusion lymphoma was considered. So as per our investigations, hemoglobin was 13. Basic blood investigations did not were within normal limits. BBVS was negative, and sputum, MJIT, and expert were also negative. A pleural fluid analysis was done, which, according to Light's criteria, was exudative. Expert PV-PCR was also not detected. Lymph node biopsy showed sections with effaced architecture by a lymphoid neoplasm, which was suggestive of a follicular lymphoma grade 2 from the left axillary lymph node. It's stained for BCL6 CD20. And bone marrow biopsy also showed erythroid and showed diffuse lymphocytosis, including a few lymphoid aggregates comprising predominantly small lymphocytes with irregular nuclear contours and granular chromatin and scant cytoplasm. It was also suggestive of involvement of bone marrow and follicular lymphoma. So the imaging that we had done, next CT, next thorax, abdomen, pelvis, showed generalized extensive lymphadenopathy, bilateral pleural effusion, larger on the left side with lobulated pleural and extrapleural soft tissue thickening. There was sclerotic lesions in the right iliac bone with no other definite skeletal involvement. All these findings were suggestive of lymphoma. So I would like to take this opportunity to talk about the risk stratification in lymphoma. Lymphoma is the most common indolent non-Hodgkin's lymphoma. So there is the different systems used in risk stratification was the Follicular Lymphoma International Prognostic Index, which takes into account age, serum LDH, hemoglobin, Ann Arbor staging more than 3 or 4, number of involved nodal areas, for which each characteristic carried 1 point for a total score of ranging from 0 to 5. This scoring system was used before rituximab came into being and was used for the treatment of follicular lymphoma. The updated version of it post the rituximab era takes into account the greatest diameter of the largest involves note to be more than 6, which accounts for 1 more point, and sera beta or beta 2 microglobulin and bone marrow involvement as well. So the prognosis based on the FLIPI-1 index includes if the patient was on rituximab, carry a 2-year overall survival rate of 98%, 2-year survival progression-free rate survival rate of 84, and median progression-free rate survival rate of 84% if the score was more than 1. Likewise, if the score was more than 3 or more, even in that situation, the prognosis in while giving treatment with rituximab, the 2-year overall survival is up to 87%, 2-year progression-free survival is 65%, and median progression-free survival is 42 months. The other prognostic index which has been used in risk stratification for follicular lymphoma is the PRIMA prognostic index. Which takes into account beta-2 microglobulin and and bone marrow involvement. Even in this prognostic index, there is a difference between whether treatment was started with rituximab or not. With rituximab, there's a 98% progression-free survival rate for for PI. For intermediate risk with 91%, and for high risk there is 78% with rituximab. So the staging classification currently used in follicular lymphoma is the Lugano's classification, which is based on the Ann Arbor classification, but is updated to take into consideration extranodal sites, B symptoms, and bulky disease. Stage 1 is the involvement of a single lymphatic region or localized involvement of a single extra lymphatic organ or site. Stage 2 is involvement of more than 2 lymphatic regions on the same side of the diaphragm, or localized involvement of a single extra lymphatic organ or site of one or more of the lymphatic regions on the same side of the diaphragm. Stage 3 is involvement of lymphatic regions on both sides of the diaphragm, and stage 4 is diffuse or disseminated involvement of one or more extra lymphatic organs, with or without lymphatic involvement. Prior to the rituximab era, there's also a Guelph criteria, which was in rampant use, which had taken into account the nodal mass size and involvement of more than 3 nodal sites, presence of these symptoms, compression symptoms, and pleural effusion, all of which our patient presented with. According to the Flippy criteria, had other than the hemoglobin being more than 12, his age was more than 60 years, serum LDH was elevated, he was Ann Arbor staging 4, and more than 4 nodal sites were involved. And then hence, even though he was graded to be follicular lymphoma grade 2, he was staged to be his staging was stage 4B, for which he was started on rituximab, and he was planned to be started on rituximab and bendamustine based on the results of the skill trial, which showed rituximab and bendamustine was more effective in patients with advanced stages of follicular lymphoma. Recently, the usage of another CD20 monoclonal antibody called obinutuzumab, which has the property of enhanced antibody-dependent cellular cytotoxicity, is also being used in treatment for advanced follicular lymphoma. This is based on the Gallim trial. Learning points is pleural effusion is one of the most common pulmonary manifestations of non-Hodgkin's lymphoma. We had seen the different staging of follicular lymphoma and newer therapies in treatment of follicular lymphoma. Thank you.
Thank you, Amrita. Any questions? You said one of your differentials to be TB. Can TB and lymphoma coexist?
Yes, sir.
How common is it?
In a country like ours, can happen quite commonly,
Do
sir.
you have any statistics? Because
I
you
have
said your pleural effusion,
I have
cytology was also negative, acidic was also negative. So is it just a part of the lymphoma that it was pleural effusion? Or can there be something else coexisting with lymphoma?
we had done a sputum and the pleural fluid expert, which was both negative. So I think it likely rules out the probability of having both TB and lymphoma.
Only lymphoma. Said patient has been having symptoms for the last 5 years.
Chronic cough for the last 5 years, but had increased in severity over the last 4 months.
Thank you, Amrita. Thank you for all the presenters who came and presented today. So today's prize goes to Dr. Narendran from Medicine 5. Thank you all for having come to the clinical meeting today, and we'll see you all next week.